There are people that actually feel, I'd rather be dead than feel this way. So I'm like, I don't even care what you think about transfusion, but man, you drew iron labs and you didn't even replete the iron.
Today, we have Dr. Micah Prochaska.
Thank you so much for having me. Micah Prochaska, I'm from University of Chicago, and I'm a health outcomes researcher who spent most of my career studying red blood cell transfusion in hospitalized patients. And it's a real pleasure to be with you. So thank you so much for the invitation.
I'm just curious, what kind of medicine are you practicing?
I'm a hospitalist clinically and trained as a classic health outcomes researcher. Went into hospital medicine in large part because it allowed me the best lifestyle to do research, because I could see patients and then be done and just do research rather than having like clinic and this and that. Every other time I was a humanities major as an undergrad, and I had always had this interest in clinical ethics. I was always on the clinical ethics faculty, but have recently been doing more clinical ethics and doing a bunch of training and teaching in clinical ethics as well.
What do you think about how much education providers get on transfusion medicine and transfusion in general?
I think it's actually fairly dogmatic. That's probably the answer. I think it's as simple as we give transfusions when the hemoglobin equals 7 or 8, whatever their attending's preference is. I don't think PBM is honestly in most residents' lingo. I have a series of papers out right now. They're under review looking at patients with severe anemia. Turns out that 40% of them have iron deficiency, and that's only the 40% that the doctors actually drew iron labs on. And of that 40%, it's like 10% get iron. So I'm like, I don't even care what you think about transfusion, but man, you drew iron labs and you didn't even replete the iron.
Yeah.
And I think this is me just shooting from the hip, but I think one of the things that's happened is that in hospital-based care, patients are so sick compared to where they were 30 years ago, 35 years ago. They have so many comorbidities that the hospital-based care is like, why are you here? Okay, you're here for this condition. Okay, you got anemia. So I am supposed to look to see if there's something wrong here, but it's not bad enough for me to transfuse you. You know, your hemoglobin's 8, so I'm not going to give you a transfusion. I'm going to draw these labs, but I'm really focused on why you came into the hospital. And the quality of life evidence in literature in anemia is that it's significant. So these people are being discharged from the hospital, and yes, you did take care of their pneumonia,
Right.
but you could have easily given them iron to replete their iron deficiency.
Yeah.
They're not going to feel that great even when they leave. I don't think people are looking at PBM or anemia holistically. I don't even know if they're really looking at patients holistically. There's other domains that I don't study that I'm sure would fit into the same thing. I think I'm sympathetic to my colleagues because I think a lot of times we have so many patients, they have so many comorbidities.
Right.
What are the things that I have to take care of right now in order to get you out of the hospital? Because I can't have you here for 3 weeks. And I think that's probably partially what's happening a little bit with our care.
I feel like anemia is a hot potato of diagnosis. Like, I acknowledge it and I see it, but I'm going to let their primary care. We get that a lot. We'll let their primary take care of it. And then the primary isn't able to take care of it, or the patient isn't even really aware that it's important.
Yeah.
I had so many people say, "Oh yeah, I've had anemia for years."
That statement about I'll leave it for the primary just drives me nuts too. I've recently started to ruminate on this a lot, and I've asked a few colleagues. I don't know if they fully buy it with me, but there's a disconnect. And I don't know if it's like a theoretical view of what my role is. Again, is my role as a hospitalist to only take care of the thing that got you here? I don't think so. Now, you could maybe counter with me and say, listen, from an efficiency standpoint, primary care docs should take care of anything that's not acutely life-threatening. Okay, so that's one argument that should be deferred to the primary care. I don't know exactly how to counter that, but what I will say is I remember being a resident when it was the last time I had a clinic. And when a patient that was hospitalized comes in to the primary care office, you also have those 20 comorbidities, and you are also dealing with all of this. And my colleagues tell me these visits are down to 12, 15 minutes.
Yeah, if that.
Yeah, exactly. If it's not my responsibility and they're overwhelmed, they're going to say, well, what's my responsibility as a primary care doctor to take care of the 3 most important comorbidities that could lead to immediate death if I don't manage them, or a rehospitalization? Well, then whose responsibility is it? The surgeons actually are really good with this conversation because they feel the same way. They're like, well, our job is to fix the surgical disease, of which anemia is not it. But anesthesia doesn't really do this. And the pre-op clinic should deal with this, but they're like thinking about the heart. So they're actually intrigued by the whole conversation about, yeah, is our job to treat anemia? I don't know. I'm going to come up with some paper about this at some point,
Yeah.
but I think it's really interesting. And I bet there's other conditions that fall into the same
Yeah.
category.
Yeah. I think the functional medicine movement may be an area of help here
Yeah.
because anemia is really one of the reasons for a lot of other issues. If you're really trying to get to the reason, instead of putting a Band-Aid on the symptom, you'll treat the anemia.
Yeah.
I
Yeah.
think there's hope there.
Yeah. And that's, again, that's the problem with the trainees is they need to be refocused that not that anemia, hemoglobin level, do I transfuse or not? That's the algorithm that they're most often using. But to recognize whether I'm transfusing or not, there's a problem here. There's an underlying condition. What's causing the anemia and why? And have I dealt with the underlying condition and examine that to make sure that there's not something else going on or that I can't treat something else? And that's where we need to rebroaden people's focus. There's an article that was published, I think, back in May or June, titled Transfusion Strategy Effect on Quality of Life in Patients with Myocardial Infarction and Anemia. This was a secondary analysis of the MINT randomized clinical trial, which probably some listeners may be familiar with, which was published back in November of 2023, I believe. Most people say restrictive would be somewhere between a hemoglobin of 7 to 8 grams per deciliter, and a liberal would be more like 9 to 10 grams per deciliter.
What would make you decide to do a liberal or a restrictive transfusion, especially in the heart attack patient population?
Well, so prior to the MINT study, there had been one other significant trial, and then MINT had a pilot trial looking at restrictive versus liberal transfusion strategies in patients with heart attacks or myocardial infarctions. While over 15 to 20 years, clinical trial data had accumulated to show that liberal transfusion was no different than restrictive transfusion in sort of general populations. One of the clinical questions that lingered in the background was, well, people with heart attacks have a very unique physiology, and that physiology deprives oxygen or deprives the myocardium or the heart of oxygen. Would a blood transfusion or a liberal strategy be better? MINT was really looking at this question, recognizing that pilot study for MINT in reality may not have adequately answered it. That was the impetus for the study. In that intervening time before MINT was published, there was various things that clinicians might consider. They might consider chest pain in and of itself enough to give someone a blood transfusion or to keep their hemoglobin higher. They might consider tachycardia, which is an elevated heart rate. They might actually consider, and this gets to my paper, just not feeling well as a reason to give transfusion. So there was a lot of unknown clinical questions that doctors really didn't know at the bedside and that the previous trials had not looked at because they hadn't looked at patients with heart attacks in particular. Again, the reason why they matter is that physiology of a heart attack is much different than any of the other patient populations that had been studied.
How does anemia affect the recovery of these patients, and why is it important to keep your hemoglobin higher or maybe not? I don't know. What does blood transfusion do for a patient that's having a heart attack?
The hypothesis that we had in our paper, and I guess the clinical question was that, so myocardial infarction or a heart attack, again, deprives the myocardium, the heart, of oxygen. When you have that reduced oxygen delivery to the tissues end up dying. Anemia, while it doesn't have the same effect of major acute deprivation, it overall lowers oxygen delivery. In people who are severely anemic, what can happen is they feel fatigued, they feel short of breath, they feel tired, so they don't feel well. You couple that with the effects of a heart attack, again, depriving the heart of oxygen, and it can be compounded. In a hospitalized patient that comes in with a heart attack, they're in the hospital, they don't feel well, they become deconditioned because they're fatigued and don't want to get up. Then as you start to try and feel better, you just feel so tired that you can't actually recondition yourself. So the theory, again, would be, well, does oxygen delivery through transfusion reduce those negative feelings, improve your quality of life, and make you feel better?
There is some thought out there that donor blood doesn't deliver as much oxygen to the tissues as your own blood. Is there any benefit to give the patient something that will help increase their
Great
own
question.
levels of blood?
Yeah. It's a little bit orthogonal to patients with heart attack, but in patients with heart failure, for sure, there's just really good accumulating data on the benefits of iron. Now, it's orthogonal, except that a lot of patients that end up having heart attacks either develop heart failure or they had heart failure to begin with. I think the state of the science is pretty strong on iron. In patients with heart attack and acute heart attack, EPO, there really isn't any data. I have to admit, I don't even know if I've fully gone through the data to fully comment. But I think the issue in those two instances is one of time. Probably not expecting the benefit tomorrow or in the next few days. The theory would be, well, does transfusion deliver that any quicker? Again, this was all a priori and some of the rationale for the study.
What surprising findings did you find when doing this study?
Well, frankly, I have to admit, I really thought there would be some quality of life benefits. We thought we would see some benefit in quality of life, that patients would actually feel better. Without getting too much into the MINT study, MINT really, in my estimation, showed that people actually have slightly improved death or myocardial infarction as their primary endpoint. So it was a study that basically was a positive study. So we thought, well, gosh, don't you think they're going to feel better too? The fact that they didn't, our analysis was pretty thorough, and we just didn't really come to any definitive conclusions that people got any quality of life benefits from a liberal transfusion.
How did you define quality of life, or how did you get that out of the patient? Because that could be subjective.
It's
What's quality to me could be something different to someone else.
Great question. And this is really important for patients. Actually, it's important for clinicians at the bedside too. We use that umbrella term quality of life, but it's really hard to measure. Okay. So in this particular study, we used an instrument, which is a fancy way of saying a survey that's been validated in patients with cardiovascular disease, not necessarily in patients with a heart attack, although it's been used in patients with a heart attack. And it's a broad quality of life measure. So the instrument was the EQ5D5L, and it actually has 3 different domains of quality of life. The first measure includes 5 domains: mobility, self-care, pain, discomfort. I'm forgetting the other 2 right off the top of my head. So it measures your quality of life in all those areas. Then you have what's called a utility index score, which are complicated even for those of us who do health outcomes research if we're not a health economist. But it's a way of assessing how people view their quality of life on a continuum. Actually, if you read the paper, it can be a little confusing because you actually can have a negative utility index score, which means you view your quality of life as worse than death. There are people that actually feel, I'd rather be dead than feel this way. And then what's called a health today rating, which is just rate your health on a scale of 0 to 100. So each of those different ways of measuring quality of life are included in this EQ5D5L.
Yeah.
Now, what's nice about that is it's broad and it takes different looks at quality of life from different measures. The negatives and the limitations of such an approach is that people say, well, oh, that's good, but I just have chest pain. And that's what's driving my quality of life. So the alternative approach is a much more disease-specific or condition-specific quality of life measure. One of the limitations of this study is we didn't do that. This represents that it's just hard to figure out what approach you want to take. Do you want the global approach or do you want a very specific tailored approach? I think, Christina, you point out it's subjective, but it's also subjective over time. Most of us, when our alarm goes off in the morning, feel tired. And then we have a cup of coffee or a cup of tea or whatever it is, and we wake up, we feel a little bit better. And then sometimes at 11 o'clock in the morning, you start to feel like I'm a little hungry and a little fatigued. And then you eat lunch and you feel better. Usually many of us by 2 o'clock in the afternoon, we feel a different level of fatigue.
Sure.
So if you think about that in a normal, healthy patient, now think about a patient that's in the hospital that's just had a heart attack. And when we go in to collect this data, can affect how they respond. So it's not just that it's subjective within an individual in a given day over time. And when we collect it actually might affect how they respond. If I ask you at 2:15, your answers might be different than if I asked at 10 in the morning.
Right.
So it's really complicated to study. It doesn't mean we shouldn't study it. It actually means we should study it. This is the area I've spent my career in, is studying quality of life. And I think for researchers, it can be daunting because of how difficult it is to study.
Yeah.
But for patients, they care about mortality. They don't want to die. We all know that.
Right.
But that's easy to study. But beyond not dying, patients want to feel well. And we just don't do a really good job of studying quality of life. That's not just in blood management. That's truly like across the board. It's really hard to study. And so people shy away from it. So that's a long answer to your question, but I hope it gives you some
It's a
insight.
great answer.
Yeah.
No, great.
So do you think the study was powered high enough? Because it's so subjective, do you think maybe having more patients over a longer period of time, or maybe asking them the same question at different points of time and things like that?
That is the best question. It's right on point. So my bias is, again, as someone who spent a lot of time here, is if you really want to look at these quality of life effects, you got to do repeated measures of quality of life over time, because that actually improves your power. And you have to have a huge sample size, because the three of us differ in our quality of life, but man, in order to truly detect an effect. So as you guys know, but I'll just say it for your listeners, when you design a study and ask for money to pay for it, the sponsors, in this case, the National Institutes of Health, want to see the trial powered based on the primary outcome. Technically, that's the only outcome you can power on. Everything else as a secondary outcome has to be viewed as only in the context of the primary outcome. There's biostatistical reasons for that. So MINT was powered based on mortality or a cardiovascular, repeat cardiovascular event at 30 days. That's why we were very clear in this title. It's a secondary analysis. Now, to go back to your question, I think that particularly in the subgroups that we saw a positive signal, were probably underpowered. And I think those are important subgroups, because going way back to where this started, the physiology matters. And if we think the physiology is right and we see a signal, we should probably check it's probably underpowered. Some of my co-authors would disagree, and they would say it's truly just noise. There's a lot of patients. We had 3,000 some patients, and you really didn't see in your primary secondary analysis, it was a little weird to say, your primary analysis of quality of life, you just didn't see a true signal. And sure, enroll 10,000 patients, but that study's not feasible. And without some signal, they wouldn't do it.
Did you find that there was any connection necessarily between higher hemoglobin level and quality of life, or did you look at that?
We didn't have post-discharge hemoglobin levels. And that actually would have been one of the most important things to actually see. These patients were interviewed over the phone after discharge rather than brought back into the clinic. So that's like a major limitation. And that would, I think, have supported some of these subgroup findings even more. That would have given us more certainty. Oh, we see a difference in the hemoglobin levels between these two groups and a quality of life benefit. So we'll never know for sure. You know, that even the timing of the follow-up is challenging. A transfusion should be around at 30 days. Is it the optimal time to study quality of life? Would we expect there to be the optimal oxygen delivery? Tough to say. Probably more likely closer to the actual transfusion would be the optimal time. But when you think about doing an intervention in the hospital, so as a physician, I think to myself, okay, if I want to give this patient a transfusion to improve their quality of life, I care that it improves their quality of life tomorrow. I definitely want their quality of life better tomorrow when I see them. But I really care about their quality of life when they're home. I want that fatigue and that functional capacity to be better in 30 days, because I don't want them coming back to the hospital. So the rationale was to look at it at 30 days. And that then makes it difficult to get the hemoglobin level, to call someone back to the hospital in 3,000 patients and check. So that's why we didn't do that. But that's one of the major limitations, again, of the study in the paper.
Remind me, were these patients in the study only in the United States?
They were not. So this was an international study from patients from around the world. I'll leave it at that. You asked what other questions that raises for you.
Well, yeah, I just wondered if the culture affected answers or anything like that. Yeah, I have a million questions.
Yeah. So one of the reasons why we use the EQ5D5L is because it has been used so widely in cardiovascular research, and it's been used in international studies. And it has what's called, when you score the instrument, you score it by country or actually geographic region. And there's different weights to different quality of life domains in those geographic regions. And I have to admit, the biostatistician that I worked with, who was just phenomenal, did a lot of this. And it's now been a couple of years since I remember reviewing specifically the weights. But it's for patients. What's interesting is, how patients in Australia view these quality of life domains and how they weight them towards their overall health is different than how we do in the United States, is different than how it happens in Brazil. Does that mean the instrument is perfect and the weights are perfect? No, you could be in Brazil and have similar measures to feel similar to someone in the United States. But on average, people in different countries weight the value of these different quality of life domains on their overall quality of life differently. So it's fascinating.
Do you think that the information from this study can be generalized to other patient populations?
Yeah, I think we can. One of the nice things about Mint, and this is my humble opinion, is probably the best transfusion trial ever done. These trials are getting the experience, the knowledge. It's a huge number of patients. The investigators were all exceptional. They did a really, really good job. And I think one of the reasons for doing this is we thought, well, okay, if you just look across all patients and you sort of compare liberal versus restrictive, maybe there's just too many differences, or the statistical term is heterogeneity between people to see a difference in outcomes. We got to focus on a group where the physiology would make sense. And in this instance, we didn't see it with quality of life. So if we didn't see it with patients with heart attacks, why would we expect to see it in the general population? So I think it's both the disease-specific patient population. If it doesn't work there, do we have a biological reason or physiologic reason to see it in someone else? That seems a little bit unlikely. And then Mint just enrolled a lot of people with a lot of differences from around the world. And that, by definition, really makes it generalizable. Is the answer completely closed? Well, nothing in science and medicine is completely closed ever. But I feel pretty strongly that this is really a big step in answering this question about quality of life and transfusion. I would think it's generalizable.
What do you see as some of the next steps as a researcher? What's the next thing you want to look at? Are there other things you want to look at related to quality of life or patient care? Because obviously we want our patients to feel good. What we do for them, we want, like you said, long term, not just get them through the hospital and then discharge. We want them to actually feel better.
This is a little bit outside the realm of transfusion, but it's in the realm of PBM. One of the things that I've been spending time on even before this came out was looking at quality of life and iron. As we talked about, there's some really good data on iron and quality of life in certain patient populations. One of the questions is that generalizable, and who should be getting iron? I think the other thing that is outside the realm of PBM that I've worked on a lot is trying to understand quality of life better and try to design interventions that can address that, whether those are PBM interventions or anything. And maybe the best way to say it in the context of this paper is, okay, well, a liberal transfusion strategy didn't help quality of life. It didn't hurt quality of life. But these people still have poor quality of life. It's nice for for me to write a paper and come on your podcast, and I feel good. Oh, we answered the question, does transfusion improve quality of life? These people still don't feel well. What interventions can we do? And is it an issue of measurement that we're not measuring this quality of life well? And so I've spent time looking at trying to actually combine the measure of fatigue and activity and look to see whether that might be a more focused way of looking at quality of life in patients, or whether there's just some domains that people don't care about or matter more or matter less.
It drives me crazy when I hear people say, oh, the doctor wants to give you this transfusion. It'll make you feel better. Or even the provider says, this is going to make you feel better. Or they give a transfusion. There's an emotional attachment to it almost, that this is going to be great.
Yeah. Yeah. And I think hopefully it's a fairly high profile journal, and I hope that the message gets out. Practice patterns are so hard to break. They're so hard to break. And there is a lot of gray area, but once we do accumulate enough evidence, we really should be better as an industry in trying to figure out, what does it take to implement standard practices and best practices? It doesn't mean we can't change them as more information becomes available. We're always willing to adapt. But why it takes so long for some of the evidence that we generate to go into clinical practice is probably the eternal question of our lifetime.
Yeah, definitely transfusion, in my opinion, is driven by culture rather than data a lot of times.
Most of the time. Yeah.
Yeah.
I really like this paper because I feel like you looked at the patient more holistically. the way nurses do, because it's not just about the treatment or the drug or whatever. It's about the community. It's about exercise. It's about nutrition. These are all things that I think
Yeah.
that we really need to start being a little bit more cognizant of
Yeah.
as clinicians.
Yeah. Oh, one of the things that I just can't stand with the residents is often now they actually know the data. So they want to do the right thing, but they really just report to me a hemoglobin number, which is great because I want to know that hemoglobin. I also need to know how the patient feels and what else is going on. We can get in both directions, actually. We can get anchored on the way we practice without thinking about what the patient looks like in front of us. Maybe a pitch for a paper that I hope will get published soon. We took a look recently and submitted this manuscript at what reasons doctors consider transfusion. What are the things they care about? It turns out that if you ask doctors what do they care about, they say sort of a vacuum. They say, well, I care about patients' quality of life. I want to know how they feel, all these other things. In reality, what do they actually do? They only care about the hemoglobin level.
Yeah.
Now, their practice may actually be accurate with the standards or not. I don't know. But we are well-intentioned in what we say, but often it can't live up to our own standards.
Right. Oftentimes, those hemoglobin levels are arbitrary. Like this paper is a little bit more of a specific patient population. But generally speaking, to be honest, someone just picked that number.
Oh,
and
yeah.
And that's what we use. And like you said, frequently it's just based on the number. They're not basing it on patient symptoms or quality of how they feel.
Right. They might say to me, the hemoglobin was 7.6 today. And then tomorrow they come in and they say, well, 7.5. So I gave a transfusion. Not sure that there was a difference between yesterday and
Right.
The question of the transfusion, we can still talk about whether we should have given that, but there really was no difference between these two today. One of the things that is true throughout our lifetime, and we're just accumulating more and more information, is for better or worse, patients have to be their own advocates in the healthcare system. There's a body of literature on patient activation, how activated you are about your own healthcare. And it is so predictive of your outcomes. It's a sad story in many ways because it means if you don't do that, the healthcare system, unfortunately, is not designed to maximize your outcomes. Not because there's any one bad actor. In fact, everybody wants to do the right thing, but it's complicated and complex. Patients who are engaged in their healthcare, they're the ones that can say, why are you giving me this transfusion? Hold on a second. You said I'm going to feel better after I get this. What do you mean? Am I going to feel better tomorrow? Am I going to feel better in 2 weeks? Like, why are you exactly giving this to me? That discussion right there is enough to produce better outcomes in patients.
This is why we talk about informed consent and teaching patients all the time. And this is why we have this podcast, because we want patients to understand and be engaged in their own care, because it does lead to better outcomes.
Absolutely.
Yeah. So is that what you would recommend? If your family member was in the hospital and they needed a transfusion, what would you recommend that they do or ask?
Yeah, I would say why, based on what, help me understand. Or if the doctor says, we're not giving you a transfusion, I would say back, perfect, fine. Then what else are we going to do? How else can I feel better? What else is it needed to feel better? I think all of us that have had friends or family in the hospital, it is amazing, despite how versed on being on the clinician side we are, when you are a family member or a friend, it feels so disorienting. It can be hard to interrupt someone and say, I'm sorry, but you got to explain that to me again. I'm sorry, I don't know why you're doing that. Okay, if we're not going to do this, what are the other alternatives? But those are the best things at getting people and getting the clinical team to like really focus on what you need.
Yeah, and everybody's in such a state of anxiety. It's hard to take things in and understand.
Yeah.
Certainly. Yeah.
What would be your takeaway that you definitely want patients to know about this study?
The ultimate conclusion for me is that I believe in the MINT study and the MINT trial. So I was a supporter of it when it came out, when I read the results. I was not an author on that main paper. I think in patients with a heart attack, that's the one group that probably we have good evidence to support a liberal transfusion strategy, but I wouldn't do it for quality of life. So I wouldn't do it because the doctor thinks you're going to feel better. Because our study showed that it doesn't really affect quality of life. Mortality, that might be the one that you want to have the discussion with your doctor, looking at those results and say, is that the right thing? So that would be my takeaway, not for quality of life. for mortality or cardiac events. I just really appreciate being on here and the invitation, and have enjoyed myself. I hope the listeners enjoy it, and I hope it was worthwhile for the two of you. So thank you so much.